Process of labor and birth goes along with ATI's chapters 11 through 15, and this will take us through nursing care of labor and delivery, the stages of labor, how to monitor the fetus during birth, any kind of interventions when there's issues with that, a little bit about inductions, C-sections, medications during labor, and in general the nursing care of the laboring patient and the patient that is immediately postpartum. So there's two forces in a labor. It's the uterine muscular contractions and then maternal pushing efforts. So there's theories about what starts labor in general. They think it has to do with maternal and fetal prostaglandins and the hormones. So a couple different things are happening. There's pressure on the cervix, which is stimulating release of oxytocin. Those oxytocin receptors rise. Estrogen rises, so the uterus becomes more excitable, and progesterone decreases, which is relaxing that smooth muscle of the uterus. So they think in the fetus that the placenta aging triggers the initiation of contractions, fetal cortisol rises, so progesterone decreases, and there's an increase in prostaglandins, which can help stimulate uterine contractions. Basically, when we talk about the powers are a series of continuous progressive contractions of the uterus. They help that cervix to open up and dilate, to thin out or efface, and that allows the fetus to move through the birth canal and expel from the woman's body. So when we talk about the passageway, we're talking about the pelvis and the soft tissues. So the soft tissues of the cervix, vagina, and the perineum have to stretch to allow the fetus to move through the inlet, the mid-pelvis, and the outlet. So prostaglandins, again, help to dilate the cervix, and relaxin, that hormone that we talked about in the first module, helps to soften and stretch the cervix for birth, and helps to stretch those broad ligaments in the pelvis. When we talk about the passenger, what we're talking about is the fetus, or the infant. So we're talking about its skull, its lie, the way it's in there, the attitude, and the presentation, and we'll go through that. So a longitudinal lie just means baby is vertical, which is what you want. Transverse lie, you can see this baby would not come out that pelvis, would not come out that vagina. So what you want is a longitudinal lie and a baby in vertex position, which is head down. So when you do a cervical exam, you can actually sometimes feel the fontanelles on the fetus, and you can get an idea of where that head is and the direction that the baby is facing. So there's variations in attitude. So vertex flexed is what we want, because that gives you the smallest diameter of what has to go through that pelvis and that cervix and vagina. Military is more straight up and down. You can see how the baby's neck is more flexed. With this, it's more straight up and down. Brow, the baby is becoming a little bit more extended. They might actually present with the brow. And then face, you can see this is the widest diameter that you can have. So you can see how that might be a very difficult, if not impossible, vaginal delivery. So 95% of term births are one of these in a cephalic presentation, so head down and in one variations of fetal attitude. Breech means that they're either butt down, so they're either complete breech like this. They could be a footling breech with one of those feet trying to come out of that pelvis, and then frank breech with their bottom right there at the pelvic inlet. So we talk about position, we're talking about the relationship between the pelvis and the passenger. So, there's a couple things that have to happen for a fetus to come out, a human woman's body. The baby has to be in the right position, the pelvis has to be adequate, and they have to sort of be in a good relationship with each other. So shape of the pelvis as compared to the position that the fetus's head is in, hopefully. This is a very short video that you can watch, and you don't need to memorize these steps of birth. This is basically what happens, but we'll talk about it in class, what engagement means. Engagement basically means the presenting part of the baby hits the ischial spine, so they're like a landmark of the maternal pelvis. Descent is that fetus coming down. Flexion is where we talked about sort of, pulling in that neck. They do something called internal rotation. They extend their neck. They have an external rotation or restitution, which is the birth, and then expulsion of the rest of the body. Again, this video is very short, but it gives a pretty clear and concise depiction of all the movements that the fetus has to do to navigate that maternal pelvis and uterus. So when we're assessing the position as nurses, what we're talking about, so engagement is when the widest part of the fetal presenting part has passed through the pelvic inlet. So if this is the pelvic inlet, these are the ischial spines, this is the pelvic outlet. When the widest part hits these ischial spines, we call that zero station, or we call that head being engaged. So the station is talking about the level of the presenting part as it compares to these ischial spines that you can sometimes feel in an internal cervical exam. The position is the fetal presenting part as it compares to the pelvis again. So we're talking about engagement is, the widest part hits those ischial spines, which is 0. Station is what level they are at. So you can either be above that, which would put you at a negative station, or you can be below that, which would put you at a positive station and closer to that pelvic outlet and closer to that perineum and vagina or vulva. So when we talk about a patient being 7 centimeters dilated, 100% effaced, 0 station, what we're talking about is the cervix has dilated, that bottom part of the uterus has dilated to 7 centimeters. It's 100% effaced, so it's completely thinned out or stretched out. And 0 station is they're talking about the head of the fetus. So the head of the baby is at these ischial spines. So mom's cervix is 7 centimeters dilated, so 7 centimeters open, starting from closed normally, 100% thinned out, and the fetus's head is at 0 station. So there's several different ways that a fetus can present. So again, we're talking about the relationship between mom's pelvis and the fetus. So LOA is left occiput anterior. So that means that the occiput of the fetus is towards mom's left side and towards the front of her pelvis. So if this is your mom, she's laying down, she's facing you, this is her, perineum. The fetus is turned towards mom's left side in the front, and the back of the baby's head, or that occiput, is right there. So LOA and ROA are what you normally see early on in labor. They're considered a typical or normal presentation. So ROA is just that occiput towards mom's right side. So again, it's the front of the pelvis, but it's mom's right side occiput of the baby. So when we're talking R, we're talking mom. When we're talking O, we're talking baby. When we're talking A, we're again talking mom. So mom's right, baby's occiput, mom's anterior. And these two letters again are talking about what side the presenting part's on, and then that A is, is it the front of the pelvis or is it the back, which will make sense in 1 second. So when we talk about OP, or occiput posterior, there you can see that back of that baby's head is towards the back of mom's pelvis. So if you see OP, or occiput posterior, that can mean a longer and more difficult labor for mom, because it's a wider portion of the presenting part that has to navigate this maternal pelvis. So the fetus is looking at the ceiling. It's more likely to get wedged against that pubic bone. Babies can be delivered this way. Many times they'll do position changes for moms, possibly put her on all fours, which will sort of open up that pelvic outlet. Again, it's a longer, more painful delivery. It could end up in a surgical birth or C-section. Babies can be born this way, but more so when we're thinking LOA and ROA. These are the typical, most desirable ways that you want the baby to be facing to have a seamless vaginal birth. OP is possible, but you're more likely to have a surgical birth. There are other complications, but for our purposes in this class, what you want your infant to be is ROA, LOA, and you want to know the difference between those two and OP and how you would take care of those patients. So there's also psychosocial psychosocial aspects of labor and delivery. So it can adversely affect maternal fear and tension. So when you think about your women that are in labor, they're thinking about this pregnancy. They might be thinking about past pregnancies or birth experiences. They have all kinds of expectations. They might have anxiety. It depends on if they have support, what they know going in. Fear has a real way of affecting how a woman's body can relate to many things, especially labor and delivery. So what you need to know as a nurse is you're going to be constantly assessing your moms, your patients, as their feelings are going to be changing. You're going to be communicating with them therapeutically. You're going to be advocating for them, anticipating their needs, educating them, and just being a constant presence for them so that fear can subside and they can know that you're there, you're their advocate, and you will walk them through this. So signs of impending labor, for a lot of people, they get energy spurts. They might get lightening, where the fetus sort of drops down, so it's less sort of into your xiphoid process up here. Baby kind of lightens up because it's engaging into the pelvis, so you might feel a relief. Women feel lots of times that they can breathe better when labor is sort of getting ready to start. Braxton Hicks contractions are contractions that are, feeling like cramping, feeling like coming and going, but they're not actually changing the cervix. If you do have cervical changes, a bloody show, or any kind of cervical dilation or effacement, that could be a sign that labor is getting ready to start. And then 12% of women or so, their membranes rupture or their water breaks before they have any signs of labor. When we're talking about true labor versus false labor in this class and in general, true labor is you're having contractions at regular intervals. They're increasing in frequency, in duration, in length. You might have pain in your lower back. It radiates towards the abdomen. True labor is that dilation and or effacement of the cervix. So if the cervix is not changing, so you're having Braxton Hicks contractions, you're having contractions 5 minutes apart for 2 weeks. If those contractions are not doing anything to the cervix, then it's not really labor. If you have contractions and you're, coming to the hospital, you're 2 centimeters dilated, 50% effaced, and you take a walk, or you have 2 big glasses of water, or you get in the shower, the nurse checks you and you're 4 centimeters, or you're, 2 centimeters still, but maybe 80% effaced, then that cervix is changing, so that's true labor. So you need to have cervical change to have true labor. And again, another example is, walking may make pains worse. With false labor, usually walking or getting in the tub or getting in the shower or relaxing sort of helps that pain to subside. Basically, with true labor, no matter what you do, it's not going to stop. It's going to get worse, it's going to get longer, it's going to get stronger, and it's going to change that cervix. So if you are the admission nurse, you're going to have OB triage orders and then OB admission orders most of the time. You're going to do a general assessment on your patient for psychological status or pain level, your general hospital assessment like you normally would. You'll assess the due date. That's very important because it's very important to know, am I expecting a baby that's 39 weeks, a full-term baby, or is this woman, having contractions and dilating and effacement, and she's only 26 weeks pregnant. That's going to be, you're going to have huge differences in how you treat the situation depending on what that due date is. One of the first things you'll do is put the ultrasound and toco on your patient, check her vital signs. You'll check that cervix to see where it is, if she's dilated, if she's effaced, where the baby's head is, the position of the head. Because again, it's important to know, if you do a cervical exam, and you don't feel like the baby is head down, you want to report that to the provider so you can make sure that you're not laboring a woman that's going to have a breech, or you're not helping a woman to labor who's going to have a breech baby, and you don't have the hospital capabilities to really help with that. So you really want to know, is she dilated? Is she effaced? How far down is the baby? And what position is this baby in? You're going to assess the fetal membranes, so nitrazine, Fern, and Amnisure are just ways that you can check if her membranes have ruptured. You can use a nitrazine strip or an amnisure. Ferning is, you can see on the microscope that it actually looks like a fern plant or a fern tree, because many times there can be urine or it can just be, sweat or water, and you want to make sure if you have a patient that has a wetness that you're assessing to make sure, is it fetal membranes, and if they are they clear? Is there meconium? Is there any kind of other intervention that I have to do or be prepared for? You're going to get your patient's general overall condition, her health history, and you're going to get labs when she is admitted to L&D as well. So for stages of labor, there's 4. And again, it's not like you're going to need to list the stages of labor, what happens in the first stage or what happens in the second stage. It's more so you need to understand if you're asked a question and they're saying, your patient's in the 3rd stage of labor, blah, 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 what that means. So how it would change what you're going to do, how it would change your intervention or your understanding of the situation. So in general, the first stage is the onset of regular contractions to complete dilation or opening and effacement of the cervix. So there's 2 phases. Latent is 0 centimeters to 5. You can walk around at 3 centimeters, at 4 centimeters. It just depends on your body. Once you get to active labor, they call that now 6 centimeters. Usually the active portion of labor lasts a much shorter period of time than that latent phase. Again, you can be 2 to 3 centimeters walking around, going to school, going to work. Once you hit active labor, most of the time, you're really going to start moving things along. The second stage of labor is once you're 10 centimeters to the birth of the newborn. So this is basically the pushing stage through birth. The 3rd stage is the delivery of the placenta. It's usually within 5 to 30 minutes of an infant birth. And you'll want to know the signs of that placental separation. So baby's born, within about 5 minutes, there's signs that the placenta is separating from that lining of the uterus. So you might see a gush of blood or a lengthening of the cord. You might see mom's uterus sort of, you might actually be able to see like a little sort of globular shape or something, because basically that cord, throughout each contraction, those vessels are becoming less and less, it's becoming less and less connected to that uterus with each contraction, and then the infant's born, and then finally after the infant's born, that placenta will detach completely from the uterus, and that will actually, the woman will actually sort of give birth to that as well. We don't cut the cord immediately. Most of the time they'll do delayed cord clamping. So the infant will be born, they'll wait until the cord stops pulsing till it's white, so that infant can get all that sort of blood flow from the placenta, and then usually the placenta will, or the mother will feel a couple more contractions, and she will push that placenta out, and that's when birth is complete. So fetus is out and placenta is out. And then there's a 4th stage, which lasts between 1 to 4 hours after delivery, and that's when the uterus is contracting to control that bleeding at that placental site. So she might still feel cramping, she might be uncomfortable. It shouldn't be as bad as contractions, but it is intense because that uterus is really doing its job of clamping down to control that bleeding at that placental site. So in the latent phase of stage 1, you have the beginning of regular contractions. They're usually mild. They increase again in frequency, duration, intensity. The cervix is beginning to dilate and efface. So we'll talk about it in class. We have just like a little visual where a balloon is, if you put a golf ball inside a balloon and you blow that balloon up, when you have true labor, and you squeeze that balloon from the top, you can see that small little neck, that cervix, is sort of thinning out, shortening, opening up. If you squeeze your balloon in the middle, like an abdominal contraction or Braxton Hicks, that cervix, that sort of the bottom part of the balloon where you blow it up, won't really do anything. So we just have a little something that we see in class that really helps with the visual of that cervical change. And again, in the early stages of that, in the early phase of stage 1, there's little to no fetal descent. So the fetus is not coming down the birth canal. In the active phase, there's more anxiety from your patients. There's a sense of need for energy and focus. The fetus is, progressively descending. So these contractions, they become more frequent, about 3 to 5 minutes apart. They become longer. They get more intense. Women might feel more intense rectal pressure. They might actually sleep between contractions because of the hard work that's happening in this active phase of labor. The support person may start to feel fatigued and sort of wonder, what can I really do at this point? And your nursing care for the phases depends. So you're going to support your patient, you're going to provide her education, you're going to, tell her about position changes, you're going to advocate for her, you're going to have the baby on the monitor, you're going to ask her in the beginning, what's your goal for pain control? Do you want to do it naturally? Do you want to try to use water? Do you want to try to use movement? Or do you want to try to use medication? And here are your options for medicated birth. So you'll want to know that on assessment, sort of what her plan is. And then you also want to understand that plans should be fluid because things change and people will change their minds. So whatever your patient wants, you just want to educate her and you want to advocate for her so she has the best chance of choosing, the best way to control her birth. So many women come in, they have a goal of a non-pharmacological birth. They go all the way, they do it. Some women have that goal and they want pain medicine right away. Some women are like, just let me know, just keep asking, see where I am. It just depends on your patient. You're going to have to create that rapport from the beginning of her her admission. So nursing care in stage 1. So you're going to be monitoring the fetus. Evidence shows that low-risk patients could have intermittent monitoring, so either a handheld Doppler or fetoscope and palpating the contractions. Most of the time, high-risk women, they're going to have continuous electronic fetal monitoring, either external or internal. We'll talk about both. So once you get induced, though, so once you come into the hospital and you get oxytocin, or once you get an epidural, you're considered high risk, so you're going to most likely have continuous electronic fetal monitoring. If you come in, and you're 5 centimeters already and you don't want any medication and you want to get in the shower and you want to take a walk, it is an option for women to have intermittent auscultation. It's just going to be a conversation that you have between her, yourself, and the provider. So you can assess your fetus, assess your baby, make sure that you have all the information that baby's doing okay in utero, but also not necessarily having a mom tied down to electronic fetal monitoring if she's low risk. So there is an ultrasound transducer to hear the fetal heart rate, and then there's a toco transducer to detect contractions. So all this is doing is showing you the length, not strength. So it's showing you how long the contractions are and how far apart they are, but this external toco is not measuring how strong they are. Accuracy can be affected by maternal habitus, position of the fetus, and movement. Some of these electronic fetal monitoring, the external ones, they can be mobile and some can be waterproof. So some women that really might sort of be into or might fit into the high risk category could have continuous electronic fetal monitoring but still be mobile. And then there's an internal way to monitor the fetus. You can have a fetal scalp electrode, which evaluates fetal heart rate and variability in relation to the contractions. And then there's also something called an intrauterine pressure catheter, or an IUPC, and that's placed into the amniotic space, and that measures the strength of the contractions. So if you think about the toco, sort of relates to the IUPC, except the IUPC is more accurate, more invasive, as it's an internal monitor. And then the ultrasound, where you can hear the fetal heart tones, sort of relates to this fetal scalp electrode. Both things are allowing you to evaluate fetal heart rate and variability, but this is an internal device that actually screws into the top of the fetus's scalp. Again, if there is issues with mom's size or baby's position, or you can't really keep the baby on the monitor externally, these are things you have to have in order for. Again, they're high risk. For this, you have to have your membranes be ruptured so it can be placed into the amniotic sac, and that's going to be a provider decision on which ones to use, but you'll need to know as a labor and delivery nurse how to do both types of electronic fetal monitoring. So again, external is just here's your TOCO, here's your ultrasound, and then here is the fetal scalp electrode that you see, and this is just a depiction of the IUPC, or the internal pressure catheter. This more accurately measures how strong those contractions are. It measures in millimeters of mercury, similar to when you're measuring blood pressure. So this TOCO is just kind of giving you an idea of, yes, she's having contractions, they're 2 minutes long, or they're 60 seconds long, they're 2 minutes apart. This IUPC is actually showing you in units the strength of the contractions. You'll learn more about that if you specialize in labor and delivery. It's not something that you need to know for our class, just that they exist, just that they're an invasive way to monitor the fetal heart tones. So first thing that you're going to do, so you're going to assess your mom, you're going to check her vital signs, you're going to admit her. Let's say, you checked her, she's 4 centimeters. The provider says, okay, well, let's, let her walk the halls. She's doing okay. You check her again. She's 5 centimeters. So, she's having change. She's a little bit more effaced. So they say, okay, we're going to admit her. You do your admission assessment, you do your vital signs, and then one of the first things you're going to do, or even in triage really, is put this ultrasound on mom to determine your fetal heart rate and to see if she's contracting. So the definition of the baseline fetal heart rate, that's what FHR is the average fetal heart rate observed between contractions during a 10-minute segment. So when we're looking at the segment, we're looking at averaging these numbers. So each of these little teeny boxes is 10 seconds. Each of these bigger boxes right here is 60 seconds or a minute. So anything, and right here, here's our 150, 140, 130, 120. So you're looking at a baseline, the average between contractions, looking at a whole 10-minute segment. So you can see that the average here, minus the accelerations where the contractions are, because this is fetal heart rate up here, this is contractions down here. So if you think about it, this is baby, this is mom. So we'll say our baseline is 130, 135, looks like. Anything lower than 110 for these 10 minutes sustained would be fetal bradycardia. Anything higher than 160 for these 10 minutes would be fetal tachycardia. So you want to be able to recognize, you want to look at a strip and be able to say, okay, I know what the baseline is, I know what a normal baseline is, which is between 110 and 160, and then if it's not normal, why is it low or why is it high? So nursing care, and what am I going to do about it? Nursing care for bradycardia, you're going to assess mom's position, because again, we talked about, supine hypotension. If mom has low blood pressure, that fetal heart rate can also lower. So you want to see, are we using oxytocin? Because that can cause, a hyperstimulated uterus, a lot of contractions, not giving anybody, mom or baby, a rest period. That can result in fetal bradycardia. Contractions can sometimes cause it. Certain medications, certain narcotics can cause it. So you want to see what's happening. Nursing care for tachycardia, one of the first things you want to do is assess mom's temperature. That can be a reason that baby is sort of compensating and having a higher heart rate. You want to see if mom's dehydrated, if she needs some fluids, and also certain medications can cause fetal tachycardia. So, if you put your mom on the monitor, you have your baby on there sustained for 10 or 15 minutes, she has a sustained fetal heart rate of above, 160, 170, you want to check mom's temperature, check her hydration, see what's happening, see if you can intervene in any way, and that's something you want to talk to your provider about. And the same thing for bradycardia. You want to say, okay, I changed her position, she's not using oxytocin yet, she's not having contractions, so you want to do a little bit of your investigation before you, tell the provider those things. So you want to sort of check and see, what can I do to intervene? Did anything change? So, if you have, you're calling the provider and you're like, my baby's been tachy for 10 minutes. The provider's going to say, okay, well, what did you do? Or what's mom's temperature? Or what else is going on? So there's certain things that you're going to need to know. I have to check before I give this information to the provider to see what the plan is. So the next thing you want to do after you get baseline is determine variability. So what variability is it's defined as fluctuations in the fetal heart rate. So you see these little boxes we talked about are 10 seconds each. So between each box, you have a little bit of a fluctuation. So your peak and your trough, you want that to be between about 5 and 25 beats per minute of a difference. If you don't really see that fluctuation, that's what's called absent variability. So here you can see, there's no real variability when you're looking at each second compared to each second, or each beat compared to each beat. That can mean fetal asphyxiation, and you definitely want to be immediately evaluating that. Minimal variation, so that's less than 5 beats per minute of a difference when you're looking at beat to beat. So you can see it's a pretty straight line, but there is a little bit of change, so less than 5 beats per minute, but not exactly 0 or undetectable. So medications can cause that. Fetuses can have sleep cycles, so you might see that for 20 minutes or so. There could be an issue with the cord, so again, you want to investigate. Did mom just get a narcotic, or is baby sleeping? If we give mom a drink, does it cause her variability to change? And then when we're looking at moderate variability, that's a difference of 6 to 25 beats per minute, again, when you're comparing each beat to each beat. So that's ideal. That's what you want when you look at fetal heart rate. You want that variability to be between 6 and 25 beats per minute. So it's okay. There's no interventions we need. We just know, okay, baby's oxygenated, baby's doing okay. There's nothing that I need to do. And then marked is a less common response to hypoxia. Sometimes babies will really compensate while they're in there. It's not necessarily bad, but you do want to investigate, why there's such a big difference between each beat. So why is there greater than 25 beats per minute difference between each beat? Again, it's a less common response to hypoxia. Most of the time what you're going to see is sort of a minimal variability. So variability is important for you to understand because they found it's the most important predictor of adequate fetal oxygenation. Having that variability between each beat, between each heart rate, that's really what you want to see in a healthy baby. So again, moderate variability, the definition of that being 6 to 25 beats per minute, that's what you want to see when you're looking at your fetal heart tones. And again, it's a grade of fluctuation, so it's basing it on that peak and that trough, so they want it to be between 6 and 25 beats per minute of a difference. So after you've determined your baseline and after you've determined your variability, the next thing you want to do is determine if there's accelerations. So what accelerations are abrupt and transient increases in the fetal heart rate for at least 15 beats above the baseline for at least 15 seconds. So if we say our baseline is, 135, an abrupt, so abrupt and transient increases in the fetal heart rate are called accelerations. So if they are at least 15 beats above the baseline for at least 15 seconds, that's what we call an acceleration. There's no intervention needed. You're just going to monitor this. This is actually what you want to see. You want to see good variability. You want to see a baseline between 110 and 160, and you want to see accelerations, which again are those abrupt increases in the fetal heart rate for at least 15 minutes, or at least 15 seconds, and you want it to be 15 beats above that baseline. Again, your nursing care, you're going to monitor, you're going to document, and there's no intervention necessary. The next thing you're going to do after you determine accelerations is determine if there's any decelerations. So a deceleration is an abrupt or gradual decrease in the fetal heart rate. and there's several that you'll need to know. There's early decelerations, there's late decelerations, and then there's variable. So early meaning the head is getting compressed, and we'll talk about this. So for fetal head compression, an early deceleration sort of matches the contraction. So fetal heart rate decelerates as the contraction peaks. That's normal in head compression. Most of the time there's no intervention that you need to do, but you do want to investigate. So if you're early on in labor, or if you have a preterm baby, you want to just investigate, why are these decelerations happening? But most of the time they're expected, especially later in labor as the fetal head descends. A late deceleration is more so caused by uteroplacental insufficiency. So there's some sort of deficiency between the uterus and between the placenta, and the baby is more so reacting to the contractions. So here you can see, fetal heart rate is going down, but it's not even really starting until the peak of the contraction. So it's more of a reaction. It's more something that needs to be immediately, you need to immediately intervene and figure out what is happening. And then a variable deceleration, they believe, is because of cord compression. So it's variable, meaning it's just that it might be related to a contraction, it might not be related to a contraction. And that, what you're going to do is move mom, because if you have, a cord around the head or a cord around the body and you put mom in a different position, that might be enough to stop those decelerations from happening. So nursing care, you'll want to know, again, we talked about. So early decelerations, so that head compression, they're sort of mirroring the contractions. That's a gradual decrease in the fetal heart rate with the onset of the deceleration to the nadir is greater than 30 seconds. So, our baseline's 140, 145. So onset, the beginning of the deceleration to the very bottom, which is called the nadir, takes more than 30 seconds. So it's a gradual decline. And that matches up with the peak of the contraction. So nadir matches the peak. They almost mirror each other. So they're opposite of each other. And then mom stops contracting, and then baby goes back to the baseline. Again, nadir, gradual, takes more than 30 seconds. It's matching the peak. Contraction ends right here, so mom's having a rest. Baby goes back to baseline, totally expected. It can happen with the head compression as the fetus is descending through the birth canal. And again, it can also happen in early labor if the fetus is premature or in breech position. So you are going to investigate, but most of the time there's no intervention needed. Variable decelerations, again, are abrupt decreases in the fetal heart rate of greater than 15 beats per minute measured from the most recently determined baseline. So here, the onset to the nadir, so the beginning of the deceleration to the very bottom of the deceleration, happens in just 2 boxes. So that's, 15 seconds. So the beginning of the deceleration to the very bottom of the deceleration is abrupt. It happens in less than 30 seconds. Most of the time, it's attributed to umbilical cord compression. So for some reason, that cord is, around baby's neck, it's around baby's body, and it's causing those abrupt variations, and then mom moves and they come back up. So your nursing care is going to be the 3 P's. So if mom is being induced or has Pitocin running, you're going to stop that. You're going to change her position, because sometimes position, again, can be all that's needed to stop those. You're going to contact your provider. An amnio infusion might happen, which is where you're actually infusing normal saline into the amniotic sac to give that baby some more buoyancy. And also you're probably going to use high flow oxygen via face mask. For late decelerations, again, that's sort of back to similar to an early, but it's happening a little bit at a different time. So it's gradual. So unlike the variable, that's abrupt, but like the early, that's gradual. You have fetal baseline, 140. It takes more than 30 seconds to get to the very bottom of that deceleration. But you see here is the peak of the contraction, and it's not even really starting until the peak. So this fetus, this baby is reacting to that contraction. So they think that that is because of uteroplacental insufficiency. And you can have decelerations towards the end of labor while the head is really descending. But this is not something that you're going to watch for very long. You're going to intervene. You're going to move mom. You're going to stop Pitocin if it's running, because that can cause maternal hypotension, which can cause this bradycardia. You're going to contact the provider. You're going to have high flow oxygen running, most likely, and you're going to have fluids. So an easy way to remember it again is at least the 3 Ps, which is you're going to stop Pitocin, you're going to reposition mom, you're going to call the provider, high flow oxygen via face mask, and probably an increase in fluids as well. So again, this is generally thought to represent uteroplacental insufficiency, which does happen at the end of, the end of pregnancy and during labor, but you just don't want to watch this happen continuously and have the effects of hypoxia on your fetus. So you're going to intervene. This is just an easier way to see what you're going to do, and this is what you're going to need to know for this class. Veal, chop, mine. So variable deceleration, cord compression, move mom. Possibly the 3 Ps, might give her fluid, might give her an amnio infusion. So you need to know what kind of decel is happening, why is it happening, what do I do about it? Or, what's happening with her fetal heart rate and her TOCO? Do I see accelerations and great variability? Okay, well that's great. There's nothing that I need to do. If I see early decelerations, why is that happening? Again, those are mirroring the contractions. They believe that's because of head compression. And the I is for investigate. Likely it's okay, but, could mean baby's breech. You definitely want to check them out. In general, you're going to continue to monitor and document. And then late is the P is for uteroplacental insufficiency, and the E is for execute your interventions. So again, those 3 Ps. You're going to stop Pitocin if you have it running. You're going to contact your provider. You're going to reposition mom because maybe her, maternal hypotension is causing that bradycardia. So this is just sort of a easier way to understand your care and your responsibility should any of these happen. So veal, chop, mine. So veal, chop, mine. Variable, we believe, is cord compression. You're going to move mom. Early is head compression. You're going to investigate. Accelerations are okay. There's no intervention needed. You actually want to see them. And then late decelerations, uteroplacental insufficiency, and you're going to execute your interventions. So other nursing care in stage 1 is pain control. So obviously pain threshold and tolerance, support, fear, all of those things can determine how a woman deals with pain during labor. The sources of pain are dilation and stretching of the cervix, stretching of the vagina and perineum. There's reduced uterine blood supply during contractions, and that pressure of the fetus on the pelvic structure. So we'll learn a little bit about non-pharmacological and then pharmacological pain interventions. And again, your nursing care is knowing the timing of pain control and the appropriateness of interventions and or medications. So, if you have a mom that's early on in labor, what you might offer to that mom is going to be different than somebody who's 8 or 9 centimeters and feels like she has to push. So, we'll talk a little bit about, what you're going to offer your patients and when. So you can always offer position changes, water, music, massage. It just depends on what your patient has communicated to you is acceptable for her or what she wants to do. It doesn't harm mom or fetus. It doesn't slow the labor down. There's no allergies or adverse reactions to worry about, but it does need to be rehearsed early to be effective. So she does sort of have to have had a plan and to know, this is what I want to do, this is what I want. These are my options. And then there's pharmacological interventions that you're going to need to know about. So analgesics, which lessen the pain without eliminating that loss of feeling or muscle movement. And then anesthetics, which are partial or complete loss of sensation. So we'll talk a little bit about systemic medications because they affect the entire body, including the fetus. And then we'll talk a little bit about regional medications, which affect a region of the body, as in an epidural, so below the waist. So these are some options for systemic analgesia. You might see Dilaudid or Demerol given, fentanyl sometimes, Stadol, nalbuphine. You're going to need to know the generic names. Also, what you're going to need to know is for a systemic narcotic or analgesia, you're going to not administer that if birth is believed to be possible within 1 to 4 hours. So because this is systemic, it can affect your fetus. Your baby can be born sleepy. Then you might have to have, nursing interventions that you wouldn't have had to have otherwise. So if birth is imminent and or within, the next 4 hours, which is hard to gauge, you're not really going to be offering a narcotic. This would be more so a time when you would offer an epidural or you would offer non-pharmacological pain relief. Also, opioid agonist antagonists like Stadol, Nubain should not be given to women with opioid dependence because it can precipitate maternal and neonatal withdrawal symptoms. So that's something that you want to know, again, about your patients. So there's epidural anesthesia, there's local anesthetics, and an opioid analgesics. Usually they are inserted into the epidural space. It's the most commonly used pain method in U.S. labors and births, and it can affect the uterus, the cervix, the vagina, and the perineum. But again, it's not systemic, so you can use your arms, you can, move your body around. You are pretty much going to be confined to bed. Most of the time, there'll be an order for a catheter once there's an epidural. Sometimes they could do bedpans or straight cath. But a lot of the times women will have an indwelling catheter once an epidural is placed. For nursing care, you're going to need to know to assess your patient expectations. So to let her know, this epidural might take away the sharp pain of a contraction, but you really don't want it to take away that pressure, that rectal pressure. You really want them to have that pressure so they can understand where they're pushing when they get to the pushing phase. You're going to infuse about 500 to 1,000 mLs of IV fluids as ordered before an epidural, and you're going to monitor maternal blood pressure. So a major complication is hypotension, which again we talked about can lead to a fetal bradycardia. So when you're looking at your fetus and you're looking at your fetal heart tones, and your fetus is has a baseline 150, 140, and you see bradycardia either in decelerations or you see a lower than normal actual fetal heart baseline, most of the time that's because of epidural, so maternal hypotension, or the effects of oxytocin. So you have to be aware of the medicines and the interventions that we are performing for mom. You have 2 patients to think about, and there are effects that can happen to the fetus as well. Another thing you're going to want to make sure you do as a nurse is provide support, assess sensation. You want to make sure she can feel her feet before she gets up after her epidural. Once the baby's born, she's trying to shower. Urinary retention is a side effect possibly. Some women itch. There's nausea and vomiting. Some women can get a spinal headache. So you want to just be monitoring for those potential complications. Again, educating her, advocating for her, and infusing those fluids as ordered. Spinal anesthesia is another option. That's a narcotic or another anesthetic such as tetracaine, bupivacaine, or lidocaine. It's injected below the spinal column directly into the spinal fluid. So instead of having a catheter that stays in place, you're getting one injection that's directly into the spinal fluid. And again, complications can include that post-oral puncture headache. Your nursing care is going to be the same. You're going to be providing support, assessing sensation. Most of the time where you'll see this is in the operating room when a woman is getting a C-section. And again, it's important to infuse those 500 to 1,000 mLs of fluids beforehand. And this just shows you the difference between the epidural anesthesia, where that's going, and the spinal anesthesia, going right into the spinal fluid. So the bearing down or pushing stage starts at 10 centimeters. The evidence shows that women don't actually have to start pushing at exactly 10 centimeters. They can wait until they have that urge. So sometimes in epidural, they'll even back off of that a little bit if she really doesn't have any of that rectal pressure or urge to push. What the evidence shows is the longer they wait for that actual pressure, the shorter the pushing stage will be. Durations are variable, so for a primip or a woman that's never had a baby before, she could push up to 3 or 4 hours. For a woman that's had babies before, it could be up to 2 hours generally. Again, you can have women that push for 5 minutes. You can have women that push for 4 hours. These are generalities. In general, while she's pushing, she's going to contract about 2 to 3 minutes. They're going to be 60 to 90 seconds long. They're going to be very strong. You're going to encourage her to rest between contractions because she can really possibly be exhausted and anxious. So for nursing care, you're going to have your delivery kit out. We'll look at them in clinical. You're going to notify your team. So if you're the labor and delivery nurse, most of the time you will have one particular person that's there to receive the baby, and then you'll have the provider. So you'll be there with mom and the provider, and then hopefully you'll have a separate nurse to receive the baby. And if there's been any issues with fetal heart tones or meconium stained fluid or any other high risk, most of the time you'll have that person receiving the infant, and then you'll also have a neonatal nurse practitioner as well. That would be ideal. So you might see a provider using warm compresses or oils. You want to help your mom be in the desired, or your patient be in the desired position, so whatever feels good for her. You want to provide privacy, comfort, and advocate for her. And then once again she's ready to push, there'll be a sterile field that will come from that delivery kit. So the next page just shows images of a vaginal birth, and there's videos online in the watch part of the module that you can see to watch a vaginal birth, a depiction of a vaginal birth, and also a C-section birth. So this just shows that crowning. So when we talked about station, that's the presenting part, right? So that's the top of the infant's head. So when you see a baby like this and it's crowning and it's stretching out, this is like +3 station. If 0 is the ischial spines, if -3 is baby's way high up in the pelvis, this would be what +3 is, which is basically you can see, 1/3 of the head is out. And then when you talk about position, so this is mom's left leg, right? This is mom's right leg. So this baby is being born left occiput anterior. So left leg, mom's left leg, baby's occiput, that back of the head is what was coming, and it was coming towards the front of the pelvis. So that's ideal, either left or right. And again, we talked about OP, which is where you would see that face facing the ceiling. So sunny side up is something that you might hear. And then the rest of the body's coming out. So stage 3 is the placenta delivery. So again, we talked about delayed cord clamping. Most of the hospitals around here do that because there is evidence to show that that's beneficial to baby. The placenta delivers about 5 to 30 minutes after the birth, sometimes sooner than that. And again, you'll see signs of separation. So the uterus might rise up and contract, especially in a smaller patient. You might see that. You might see an increase or a gush of blood from the vagina, a lengthening of the cord, because again, that fetus was connected to the cord, was connected to the placenta, which is connected to the inside, those first 2 layers of the uterus, and after birth, that's going to come apart. With each contraction, that cord is, becoming longer, that placenta is becoming, less connected to those uterine vessels. So when that placenta is ready to come out, you might see a little bit of blood come out or a gush, and that cord lengthens. And again, you might actually see it kind of rise up in a smaller woman. You might see the provider apply traction, and they're going to check the placenta for completeness because placenta pieces or any kind of fragments can cause a late-term hemorrhage. Nursing care, you're going to administer IV or IM oxytocin for postpartum hemorrhage active management, so that's prophylactically. You're not going to wait for the hemorrhage to start. Most of the time in small community hospitals, as soon as that placenta is born, or sometimes even as soon as that anterior shoulder is born, you're going to start that IV pit. If a woman doesn't have IV access, you can give oxytocin or Pitocin IM. And then patient advocacy is always a part of, all the stages. So blood loss is normal, up to about 500 mLs for vaginal delivery, about 1,000 for a C-section delivery, which we'll talk about in a little bit. There's hemodynamic changes. There's going to be a slight decrease in mom's blood pressure, an increase in her pulse. She'll return to her pre-labor values fairly quickly. Her uterus will contract. It's midline. It's halfway between the symphysis pubis and the umbilicus within about an hour. She could be shaking. She could be hungry. She could be thirsty. Again, her culture, her preferences, these are all going to influence how she's acting in stage 4. Who she wants to hold the baby, if she wants to do skin to skin, if she wants something cold to drink, if she wants something warm to drink. Those are all going to be questions that you have talked about on admission, and that you can help her so she has something that works for her and her family. Nursing care for stage 4 is you're going to continue to educate her, and you're going to help her with, perinatal care, with breastfeeding, with assessing her lochia and pain, her fundus, that top of the uterus, her vital signs. You're going to chart the delivery information. You're going to encourage mom to void as soon as she can get up and stand. Most of the time, they'll have a complete bag of oxytocin postpartum. They'll get up to shower at about 2 to 3 hours postpartum if they're feeling okay and have full sensation in their feet. You're going to help with that, and you're going to have assistance with that when she gets up for the first time. Most of the time we educate moms to ask for assistance for the first 2 or 3 times voiding, just so we can make sure that she's doing okay, because you can pull blood while you're laying down, and you can also be at risk for hypotension and fainting. So you want to make sure that you're with her those first couple times that she gets up to void. And definitely when you're putting her in the shower, you want to be right there, and you want to have assistance should you need it. So complications in labor and birth, there are many. All of these in this blue box you can learn about. Preterm labor, preterm birth, and perinatal loss we talk about in Module 2 in the next few slide decks. We will have questions about that. You do want to know about preterm labor and preterm birth. All of these other complications, I just want you to know that they're possible. I want you to read about them. I want you to look in ATI once this class is over. For our purposes in our class, we're going to talk about an induction or an augmentation as a complication, cesarean sections, how hypertensive disorders or preeclampsia, gestational hypertension affects mom during labor, and how gestational diabetes can affect her and how it can affect the infant. But any of these things are possible. There's other things that are possible, but for our purposes, these are the complications that you're going to want to know about, and that you're going to want to know how do they affect the infant when we get more into infant care. So an induction is just the initiation of labor before it begins naturally. There's many reasons that you can be induced. If you're post-term, if you have hypertensive disorders of pregnancy or gestational diabetes, most of the time they'll bring those women in for inductions at 37 weeks unless they're severely affected, and then they'll look at them case-by-case basis. PROM is premature rupture of membranes, if there's any uterine infections, if there's a fetal demise, if mom's post-dates, so beyond 41 to 42 weeks. And then sometimes there are elective inductions. There's certain criteria. You have to be 39 weeks, baby has to be head down, etc. But that's done again on a case-by-case basis. A contraindication to an induction would be placenta previa, so we talked about that in Mod 1. If the placenta is lying before the fetus in front of the cervix, that's not going to be something that you're going to induce, especially if she's 39, 40 weeks, you're looking at a possible surgical birth for that. If the baby's transverse lie or breech, they're not going to be induced. Prolapse cord means the cord is it has exited the vagina before the infant. That's an emergency. You're going to release pressure on that cord. That's going to go, you're going to be going to the operating room for that. Active genital herpes and previous uterine surgery are reasons that women probably would not be induced. They're contraindicated. So a Bishop score is something that you're going to need to know about, and that's assessing cervical readiness for induction. So the lower the score, the more a woman's going to need a ripening agent. The higher the score, the more favorable her cervix is. So you could induce her right with oxytocin, or right with, some other kind of medicine like misoprostol. So if you have a score of 0, that means your cervix is closed, The position of the cervix is posterior. There's not really much effacement. The baby is very high up, and the cervix is firm. So this person is going to need a chemical or mechanical ripening. So there's something called a Foley bulb. You can use misoprostol. You can use Cervidil, some kind of synthetic prostaglandin to get that cervix ripened before you would start with oxytocin. You can't just, give a woman that synthetic hormone when her cervix really isn't ready. There has to be a step one. So if you had a woman that came in and she was, 5 to 6 centimeters dilated, 80% efface, +1 to +2, basically like she doesn't even really need to have any sort of augmentation or induction. So the higher the number, the less steps you're going to need to induce. The lower the number, you're going to need sort of a first step. So you're going to need a ripening agent, either chemical or mechanical, and we'll talk about those. So chemical would be a prostaglandin E, so a synthetic prostaglandin such as misoprostol. You can use it intravaginally, you can administer it orally, sublingually. Most of the time during a induction, patients will get 25 micrograms vaginally. Another option for a chemical prostaglandin is dinoprostone, so Cervidil or Prepidil. That's directly into the vaginal fornix or cervical canal. The big difference between these is Cervidil can be removed, so it's sort of like a flat little tampon that sort of goes in behind the cervix that has the prostaglandin, synthetic prostaglandin on there. So if there's some issue with baby heart rate or some issue with, hyperstimulation of the uterus, that Cervidil can be removed. Prepidil is given sort of like it's given via injection, so via syringe, so there's nothing you can really do to undo that. You'd have to look at something like a tocolytic to stop if she were, having hyperstimulation or something like that. So most of the time what you'll see is Cervidil. Some providers do use Prepidil, but you'll want to know the difference. And then there's a mechanical ripening, which is a balloon catheter. So a Foley catheter is placed into the intracervical canal, and that causes cervical ripening by putting pressure on the cervix. So most of the time, women that have that, nurses will go in, they'll sort of tighten up that balloon, and women usually get to about 3 to 4 centimeters, and then that balloon will fall out. The ultimate goal is the cervix stays open. You're 3 to 4 centimeters, you're a little bit more ripened, a little bit more thinned out, and then the provider can look at having a oxytocin induction. So lower Bishop score, again, you're going to have cervical ripening agents first. If you have a higher Bishop score, you could look at using synthetic oxytocin or Pitocin for an induction. So it's a naturally occurring hormone. It's produced by the pituitary gland. This synthetic version is used to induce or augment labor and also to control bleeding and enhance uterine contractions after the placenta is delivered. So you'll want to know, all Pitocin is doing, or all oxytocin is doing, is contracting that uterus, but you'll want to know the 3 times that you want to do that. So you want to do it when you're totally inducing labor, you want to do it when you're helping labor on or augmenting it, and then you want to do it to control that bleeding postpartum. Putting the baby on the breast and nipple stimulation can help a woman to emit her own natural oxytocin, because we do make that hormone. So that's something that can be used. And again, if you don't have IV access, oxytocin can be given in its synthetic form, IM. So you always want to administer IV on an infusion pump. You want to piggyback it into the primary line at the lowest port so it could be discontinued fast. You're going to have fetal heart rate and contractions continuously monitor. And again, if there's any adverse conditions, so you have hyperstimulation, too many contractions, or you have fetal bradycardia, low variability, you're going to discontinue that, and you're going to change mom's position and contact your provider. So all augmentation means is you're helping labor along. So maybe labor started, maybe it just slowed down or it stalled. Maybe contractions became irregular or the cervix stopped changing. So an epidural can weaken contractions, so sometimes we'll sort of start that cascade of, Pitocin, epidural. The epidural relaxes moms, then the contractions space out, then you have to get more Pitocin to sort of get back where you were. So it sometimes can be a little bit of a cycle, but for your purposes, you just want to understand oxytocin is used to induce labor, to augment labor, and then again postpartum, all the time to get that uterus to contract. So there's not very many medications in this course that you need to know, but this is not one that you're going to learn in another course, so I would know everything that there is to know about it. When do we use it? Why do we use it? How does it metabolize? What are the contraindications? And then what am I looking for when I am administering it to my patient? So cesarean sections, you can have C-section because of cephalopelvic disproportion. So that's CPD. Basically means, head won't fit through that pelvis. A woman does need to have a trial of labor before that's determined. Malpresentations, so a breech baby or transverse baby, dysfunctional labor patterns, any kind of fetal distress. Most of the time in our country when women get a C-section, it's because it's a repeat C-section. It's the most common operation in our country. Interestingly, in 1965, less than 5% of births were via C-section, and currently it's more than 30%. And again, it varies tremendously by state, and also it varies tremendously throughout the world. So certain countries have very low rates of C-sections, certain countries have rates higher than 50%. So there's two types. There's a lower transverse, or the Phenostyle or Bikini, which is the most common, and then the classical incision, which is rare today, but still can be used. Again, here are the differences. And here's a little content warning because it's just showing you an image of a cesarean birth. So for your nursing care, what you need to know, so you will go to the operating room. The pregnant patient will be your patient. Nope, said that wrong. So you will go to the operating room. The pregnant patient will be the operating room staff's patient. You will be there to receive the baby, and most of the time you have a neonatal nurse practitioner with you as well. So you're taking care of mom. She's in labor. Her labor stalled. You take her up to the OR. You go to the OR. The operating room staff sort of takes over mom during the procedure. You receive the baby, and then most of the time you go right back to the floor with both mom and baby as your patients. So what you need to know is a pregnant patient should always have some sort of bump under her hip, so she's never fully supine, and you'll see that. Hopefully you'll notice that in the operating room that they have that, so mom's never really just pressing on that vena cava with that gravid uterus. And again, supine hypotension syndrome is a compression of the inferior vena cava and the aorta by the gravid uterus, and it can lead to decreased venous return, hypoperfusion. Symptoms are going to be tachycardia, diaphoresis, nausea, vomiting, low blood pressure, lightheaded, dizzy. You want to turn mom to one side to relieve that pressure. So again, hopefully if you get to see a cesarean birth and you're in the OR, you'll see that they'll, mom will be supine with the exception of a little bit of a bump underneath one hip.